Hello, everyone. Happy New Year to all, both live and online. My name is Amar Deshpande. I'm the Vice Chair for Education for our department. Welcome to the second half of Medicine Grand Rounds for this academic year. This is the first of our two chief resident-led CPCs, clinical problem case. So unlike our other, we started this a couple of years ago, and it's been very successful. So we look forward to another great year of this with our chief residents leading a discussion. It's interactive, so as you see, they'll give you some instructions on how to do that, and they'll be walking through a case and then have discussants from various specialties come in to give us more information. So Dr. Severdija and Gaddipati are both graduates of our medical school several years ago and then did their residency here and their chief residency. Ryan is going to be starting his cardiology fellowship here in the summer/fall, and Sirisha has decided to go to the greener pastures of Chapel Hill for a T32 research fellowship in the great field of gastroenterology. So we're thrilled for that. So congratulations to you both on your recent fellowship matches, and I'll hand it off to you.
Thank you so much.
Okay, hello and good afternoon, everyone. Like Dr. Deshpande said, I'm Sirisha. This is Ryan. We are the proud chief residents at Jackson's Memorial Hospital. We have a very exciting clinical case for you of a patient that's not uncommon to many of our services. And unfortunately, we have no disclosures to report. Go ahead.
Okay, so going forward, before we begin, I'll go through the session guidelines. Throughout the case, we as moderators will invite discussants who are experts in their field to weigh in on different clinical questions. The case is only known to us. The discussants were blinded beforehand, and they were only given the pertinent topic of the question we have for them today. The goal is not to necessarily get the right answer, but to instead learn from our expert discussants and gain insight into their approach to different clinical questions. And like Dr. Deshpande mentioned earlier, we hope to make this an open discussion. So we encourage anyone in the audience to jump into the conversation, and there will be multiple opportunities for audience participation. So please also have your smartphones ready, as there will be a few interactive slides.
And just a quick aside, you might want to see if you can connect to the secure Canes Wi-Fi. That might help it for the interactive portion. But without further ado, let's meet our patient. We have a 46-year-old male who presents to the emergency department with complaints of shortness of breath for 2 weeks. What characteristics do you think you'd like to know about his shortness of breath? So this is where our interactive component comes in. So let's try this first. If it doesn't, Cam, I'm coming straight to you. So if you go ahead and scan the QR code and connect to the service, we really want to know about maybe 1 to 2 words or one question that you'd like to ask or focus your line of questioning for. Pertinent positive questions or pertinent negative questions that might lead you to a clinical scenario. And I'll start singing the Jeopardy song too. Oh, it's working. Okay, amazing. Okay, constant or exertional for how long? 2 weeks. Positional, duration. Is this the first time this has happened? What are the aggravating factors? Any chest pain? I think the more times people say it, it comes up bigger on here. So you guys are all thinking along the right thoughts there. Positional, exertional, cough, acuity. Any other associated symptoms? Cough and fever. Great.
There's a lot of chest pain there. Very good.
Okay. Trying to see any sick exposures, really good question. Infectious review of system severity. How debilitating is this for him? Travel. Okay, good. And has this happened to him before? I think this is really good. You guys are going through a good illness script here. I think we're good to move on.
Yeah.
Okay.
Okay, so thank you everyone for those great questions. So let's take a second to review some of the pertinent positives and negatives taken from the initial history. The patient did in fact endorse exertional dyspnea. He noticed that he could no longer walk more than a block without becoming considerably short of breath. He also noticed increased swelling of his lower extremities, orthopnea, fatigue, and generalized weakness. He however denied, for those of you that asked, he denied any chest pain, reflux symptoms, no cough, wheezing, palpitations, dizziness, presyncope, or syncope. Okay, so on further interview, this patient had no known past medical history that he was aware of, no past surgeries, he was not taking any medications, and had no known allergies. In terms of his social history, he did endorse prior tobacco use. He endorsed that previously he smoked around a pack a day for the past 20 years, although he quit 5 years ago. He also endorsed polysubstance use, for which he was very forthright about heavy drinking, noting that he drinks at least 5 beers every night, and additionally endorsed occasional cocaine use. He's originally from Honduras and emigrated to the United States around 5 years ago. He now works in construction, although for the past few weeks he's had increasing difficulty completing the manual labor that he used to do very easily. Finally, he had no known significant family history, noting that he was not aware of anyone in his immediate or extended family of having any medical issues.
On admission, a complete physical examination was performed. We'll go over the pertinent positives, which include a blood pressure of 99/73, so a slightly narrow pulse pressure with a heart rate of 75. His head exam was fairly unremarkable. His neck exam noted no thyromegaly, but notable jugular venous distension to 10 centimeters. Before Dr. Weiss or Dr. Deshpande asked me, it was measured appropriately. We use a ruler at the border of his sternal angle and tangential light to detect his pulsations. His head was turned away from myself. And so it was notable to 10 centimeters. On pulmonary exam, his crackles were appreciated in his bilateral lung fields from the bases up to his mid-lungs. His cardiac exam was notable for a regular rate and rhythm, a 3 out of 6 holosystolic murmur with a wide split of his S1, a normal S2 with the presence of S3. He was also noted to have an inferolaterally displaced and enlarged apical point of maximum impulse, or PMI. He was noted to have hepatomegaly with positive hepatojugular reflux and pitting edema measured to about 3+ in his bilateral lower extremities up to his mid-thigh. Nothing else very significant on his physical exam.
Okay, so now let's take a look at our patient's initial labs. His CBC was within normal limits. He had no anemia or leukocytosis, and his CMP was only notable for a mild hyponatremia. However, his other electrolytes and creatinine were within normal limits. He had a normal TSH, normal liver function test, and had a negative respiratory viral panel. His troponins, however, were mildly elevated 0.642 and downtrended after repeat at 4 hours to 0.58. Additionally, his BNP was elevated to 6,000. And then finally, we had a urine tox screen positive for cocaine metabolites, and he also had an ethanol level of around 300. So let's take a second now to review our findings so far and start forming a working clinical diagnosis. So this patient has been endorsing now a few-week history of exertional dyspnea, lower extremity edema, and orthopnea. And then on exam, we confirmed the presence of volume overload with the findings of crackles, JVD, and hepatojugular reflux. Additionally, we now have objective laboratory data, including an elevated BNP, and troponin that was combined with our clinical findings that's highly suspicious for a clinical diagnosis of new onset heart failure. Now, while most of us as internists, we feel pretty comfortable making the clinical diagnosis of heart failure and pursuing the initial workup, we wanted to ask an expert to give us more insight into his approach to diagnosis and thinking through possible etiologies. This brings us to our first discussant, Dr. Weber-Pinzon. Dr. Weber-Pinzon is an associate professor of clinical medicine here at the University of Miami. He's a board-certified specialist in advanced heart failure and transplant cardiology and the director of the Advanced Heart Failure Treatment and Recovery Section at the University of Miami and Jackson Memorial Transplant Institute. He's an accomplished educator and researcher with many publications, having also led numerous clinical trials and innovative heart failure therapies. Please join me in welcoming Dr. Weber-Pinzon. Now, Dr. Weber-Pinzon, based on this patient's case, how would you approach the diagnosis and workup of new onset heart failure in this patient?
First of all, thank you for the invitation, Ryan. You have done a fantastic job evaluating this patient, so I have very little to say in terms of but you guys were able to figure it out, right? The patient has a new diagnosis of heart failure. As you guys know, heart failure is a complex clinical syndrome that is characterized by symptoms of congestion, right? Symptoms of low perfusion, low output, right? As you saw there, the patient has a lot of congestive symptom, S3 being one of the ones with the highest likelihood ratio, crackles, and all the other symptoms. Also, symptoms of fatigue, right? Now you have, as you guys mentioned already, also biomarker evidence of congestion as shown by the being-attracted peptide. Now, when we approach this patient, you have here put this basic slide to see what we do. When we approach this patient with heart failure, we want to accomplish a few things. So the first thing, we want to get to the diagnosis. What is the cause? And see if we can tease out a specific etiology for the disease, something that we can reverse, right? Treat a specific treatment disease. Now, the second thing that we want to accomplish with these patients is look at trying to define their hemodynamic profile. Is the patient wet? Is the patient warm? And how we're going to manage this patient, right? The patient is wet, the patient needs diuretics. If the patient is cold, and the patient needs, we need to improve the perfusion. There are different ways to do this. Now, we also assess the prognosis of these patients. So we look at different markers and see how these patients are going to do in the long term. Now, in this particular case, this is new-onset heart failure, so there are plenty of opportunities independently of the prognostic markers that we have. So, but these are the things that we do. We do our HMP, right? And as you guys did, our laboratory assessment, and this is based out of the guidelines. This is the 2022 HACC guidelines, and you see the class of recommendation is 1, with some of those being C or B level of evidence. Your HMP, your EKG laboratory assessments, as you already presented. Then we go into the imaging aspect of things, right? Because up to this point, as I said, there's a complex clinical syndrome with the symptoms, right? And signs and symptoms. Well, these symptoms are caused by structural and functional changes in the heart, right? So we need to define, where is this patient? What are the changes in the heart? So that's where the echocardiogram comes into play. So, and then we have other testing modalities with a lot of lower recommendation like cardiac MRI and so forth. But going specifically to this patient, right? This patient is a young patient. So when these young patients like this present to me, the first thing that comes to mind is a genetic. So I want to make sure that we have a good family history, right? You already said the family history is negative, and genetic cardiomyopathy sometimes can be tricky. Okay, so that's number 1, right? We look at the demographics, right? This patient is coming from Honduras, right? He's coming from Honduras. We have to think about diseases like Chagas disease, right? Where Chagas disease is very endemic. We also have then the risk factors of the patient, right? This is a younger patient, so coronary artery disease a little bit less likely in our differential, but nonetheless, he's actively smoking, right? He's using cocaine, so ischemic heart disease still kind of part of our differential there, right? So, and obviously the heart can be injured by toxins, so toxic etiologies are also cocaine use, alcohol use, they contribute to cardiomyopathy. So if we go to the next, right? And this is how we would approach the patient, right? After looking again the history. And for this particular patient, you already have said a lot, but you always keep in mind that you have to ask and evaluate the patient based on cardiac symptoms and signs, but also non-cardiac, because there's a lot of non-cardiac symptoms and signs that can come together with, cardiovascular etiology. Let's say patients with lamin A mutation, they can present with lipodystrophy and other markers, muscular weakness, and so forth. Right, so keep that always in mind. So the first thing that we will recommend is doing an echocardiogram, because this, again, it helps us to determine the etiology, but also help us with the treatment, because not all heart failure gets being treated equally, right? So and then we classify the patients in heart failure with preserved ejection fraction, those with more than 50%. Then we have to look at the typical etiologies, older age-related, hypertensive, heart disease, coronary artery disease, obesity, and all the traditional metabolic syndrome risk factors that you have. Is this the old lady with CKD type of HFpEF, or is this the obese patient that with metabolic syndrome type of HFpEF, right? We have to also, EDECO will provide information about valvular heart disease, right? Is the patient having tachyarrhythmias? You ask the patient's having palpitation, how the patient has syncope, because that can point you towards certain etiologies. Again, genetics, is this infiltrative? We have patients with sarcoidosis, right? And this is something I mentioned to say, this patient works in construction, right? He's being exposed to allergens. Is this a patient that's developing sarcoidosis, right? So something else to keep in mind, right? But then if the patient has HFrEF, or heart failure with mildly reduced ejection fraction, right? We have the first thing that we all do, if the patient has the risk factors to think about coronary disease, then you do an ischemic workup, which for the most part, if you have a high pre-test probability of disease, you want to do the gold standard test, which is the left heart cath, right? And you classify the patient ischemic and non-ischemic. Most of us stay there, right? That's inappropriate. It's inadequate, in this day and age, where the patient has a left heart cath, there's no coronary disease. We cannot stay in the non-ischemic. We have to figure out, right, what is the cause. Hypertensive heart disease is a very common etiology here, but obviously your imaging will tell you there's some valvular heart disease, right? The history will tell you also EKG and some other tests that we can do, tachycardia induced. We talk about toxic agents, familial, right? If you have stronger suspicion, you have to do genetic testing, peripartum. And then we have those zebras, right, where there's infiltrative disorders, which like inflammatory disorders, we can be immune, infectious disease related, metabolic, nutritional, and infiltrative disorders, as I said. So that's how we start thinking about these cases in heart failure.
Thank you so much,
Thanks so
Dr.
much.
Pinzon. It's amazing. Thank you.
So that was a perfect and excellent insight into what our next steps were for this patient. Part of the workup that you had initially indicated was laboratory, which we did do that, the full labs, iron, lipid, and thyroid function studies, which were all within normal limits. So now let's proceed to the next step of this workup for the heart failure, which leads us to our ECG. Our interpretation of this ECG is normal sinus rhythm with a bifascicular block. Specifically, you can see a right bundle branch block and a left anterior fascicular block. So looking carefully, there's an intraventricular conduction delay with a prolonged QRS greater than 3 small boxes or greater than 120, sorry, this is more tricky than I thought. 3 small boxes are 120 milliseconds. We see a broad notched positive R wave in lead V1, which tells us, I can't gesture with that. It tells us the block is present in the right bundle. And we also see a characteristic left axis on this ECG. So we see positive deflection in lead 1 and negative deflection in lead 2. We don't meet any criteria for left ventricular hypertrophy, and we don't see Q waves in the inferior leaves. So this criteria helps us meet the left anterior fascicular block. Finally, we see some nonspecific STT changes with biphasic T waves present in our precordial and lateral leads. In the absence of active chest pain for our patients and downtrending troponins, no acute coronary plaque rupture was suspected. Okay. And we're going to move on to our chest x-ray, which is one of the other imaging findings that Dr. Weber-Pinzon recommended us to get. In a systematic approach to this interpretation, we see patent airways. There's no tracheal deviation. Our patient does not appear to be significantly rotated. We're picking up some interstitial haziness with what appears to be curly B lines and peribronchial opacities concerning for pulmonary edema. We see clear diaphragmatic borders. So there's no pleural effusions. And finally, there is evidence of cardiomegaly. The edges of our patient's heart border take up, I'd say, probably greater than 2/3 of his entire chest wall frame.
Okay. And now here are some clips of our patient's initial transthoracic echo, okay, of which the official interpretation is a decreased ejection fraction, 15 to 20%. That's calculated by Simpson's biplane method. On the left, you can see our peristernal long axis view, where in addition to a sluggish contraction of the left ventricle, you can also see a severely dilated left ventricle with eccentric hypertrophy. Also, there's a severely dilated left atrium. And on the right, you can see an apical 4-chamber view that notes similar findings. Okay. And then, okay. So additionally, on the echo, we noted moderate to severe mitral regurgitation, so some valvular disease. This is an image of our peristernal long axis view centered over our mitral valve with Doppler. And you can see an abnormal turbulent jet with retrograde blood flow being ejected from the left ventricle to the left atrium in systole.
So we've identified our patient has reduced ejection fraction. So the next step in our workup was to exclude ischemic etiology. We chose to do a coronary angiogram. There was no significant coronary artery disease that was seen. However, given his new findings of heart failure with reduced ejection fraction for diagnostic and therapeutic planning purposes, a right heart catheterization was performed. We did see evidence of elevated left ventricular filling pressures with severe pulmonary hypertension and a reduced cardiac output of 2.29 and a cardiac index of 1.3. So we have our working diagnosis now of acute decompensated heart failure with reduced ejection fraction. We know it's secondary to the non-ischemic cardiomyopathy based on the results of our angiogram. The presumed etiology for our patient at this point is from long-standing alcohol use causing an eccentric dilated cardiomyopathy. So this patient then underwent inotrope-assisted diuresis with intravenous loop diuretics in the CCU. After stabilization, he was started on guideline-directed medical therapy, or GDMT, while inpatient with symptomatic improvement, so with the 4 pillars of sacubitril/valsartan, or the angiotensin receptor neprilysin inhibitor, spironolactone, which is our mineralocorticoid receptus antagonist, dapagliflozin, which is our SGLT2 inhibitor, and carvedilol, our beta blocker. Our patient was deemed not a candidate for advanced heart failure therapies, such as transplant or a mechanical left ventricular assist device, LVAD, due to his psychosocial barriers. A wearable cardioverter defibrillator device, or life vest, was provided upon discharge. He was counseled on strict alcohol cessation with cardiology follow-up, but consistent follow-up was limited by his lack of insurance. Over the next 2 years, the patient ended up having multiple readmissions for heart failure exacerbations, which were characterized by similar presentations like swelling, shortness of breath, despite medication adherence and his insistence on alcohol abstinence. On one of these admissions, further workup was obtained. So we're going to pause our case again and think about it. So he's back here in the hospital. He's with you on your team. What's the next thing that you might do for workup and management of his condition at the time? We'll put up another QR code.
Yeah.
Please, yes.
So, you know, we're in medicine, we're very prone to just quickly jump into conclusions. And I invite you all to, because we all see these young patients that they use alcohol, they use drugs, and we immediately tend to jump and say, this is alcoholic cardiomyopathy, cocaine-induced cardiomyopathy. Always keep your mind open. Always keep your mind open and think there could be something else behind. There could be a double hit type of hypothesis that is leading to this problem. Right, so that's number one. Number two, just going back to your EKG, there are some changes in the EKG that are suggestive of specific pathology. There's a right bundle branch block, there's a left anterior fascicular block, conduction disease that could tell you that is a very common finding in a specific condition. I'm not gonna tell the name because I don't want to ruin the party.
Yeah. 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 Thank you so much, Dr. Robinson. And everyone, great suggestions. I see the most popular answer was a cardiac MRI, among other things. And I think ultimately, you know, what Dr. Pinzon is saying is just labeling this a non-ischemic cardiomyopathy and saying this was from alcohol abuse is just not good enough. For those of you who said cardiac MRI, that was the exact approach that was eventually taken to further investigate possible etiologies for this non-ischemic cardiomyopathy. The official read here noted an ejection fraction of 20% with biventricular dysfunction and severe LV dilatation. On the left, you can see a 4-chamber view, and on the right, we have a short axis cut. And one of the most high-yield functions of cardiac MRI is the interpretation of late gadolinium enhancement. This gives us an in-depth assessment of the location and the pattern of scarring or fibrosis in cardiomyopathy and can shed more light on possible etiologies. The lateral walls of this patient's heart had evidence of subendocardial late gadolinium enhancement, which you could see in ischemic cardiomyopathy, but we already ruled that out with our coronary angiogram. However, you could also see gadolinium enhancement in the mid-myocardial anteroseptal segments that suggest a dilated cardiomyopathy. Finally, just to mention, based on this imaging, there was no obvious evidence for any infiltrative disease or active myocarditis. So we narrowed our differential just a little bit more. For those of you that also wanted a repeat echo, this was done on one readmission among many for a heart failure exacerbation. It was done sometime after the previous cardiac MRI. This is an apical four-chamber view with the Doppler centered over the tricuspid valve. And the official interpretation was a severely reduced LV systolic function with an EF of now 10 to 15%, as well as new findings not seen on previous echoes, such as a moderately reduced right ventricular systolic function, moderately dilated right ventricle, and severe tricuspid regurgitation. You can see this clearly on the image with the characteristic retrograde jet on Doppler. And if you also look closely on the mitral valve, you can see something that wasn't there previously. So those bright echogenic objects on the mitral valve are the interval placement of two MitraClips or transcatheter edge-to-edge repair. Essentially, it's a minimally invasive catheter-based procedure where you take clips to grasp and approximate valve leaflets, and you reduce valvular regurgitation. This was done because of the patient's severe mitral regurgitation and his poor surgical candidacy and presumed worsening of symptoms from that extremely regurgitant valve. And notably, his mitral regurg did modestly improve after the intervention, and so did his symptoms. We also have a repeat EKG from the same admission where the echo was taken, and it's not so dissimilar from the previous with that characteristic bifascicular block, the right bundle and left anterior fascicular blocks. However, the QRS is further prolonged. It's now 170 milliseconds, and there's a new first-degree AV block with sinus bradycardia. In addition to the worsening structural disease seen on the previous imaging, we can't forget about this patient's advanced conduction disease that seems to also be worsening at the same time. So given this patient's severe conduction disease with interventricular conduction delay and therefore prolonged QRS, and his severely reduced ejection fraction despite optimal GDMT for now greater than 3 months, he was recommended for cardiac resynchronization therapy with defibrillator replacement. However, due to increasing financial barriers at the time, he was unable to attend outpatient EP and heart failure clinic referrals for some time initially. So he was continued on optimal GDMT and a standing diuretic before he presented several weeks later to the ED, but this time with acute left-sided hemisensory loss and gait instability. CT angiography of the head done at that time revealed an acute right-sided P1 segment filling defect characteristic of an embolic stroke, and his new EKG now shows a new diagnosis of atrial fibrillation. He was started on anticoagulation with plans for a possible rhythm control strategy. So a lot has happened to this patient in this case so far, so we're going to take a quick moment and just recap and gather our thoughts. So we quickly determined that this patient has a clinical diagnosis of heart failure, and we worked it up and revealed a non-ischemic dilated cardiomyopathy. The etiology of this cardiomyopathy initially was presumed to be most likely from chronic alcohol abuse. However, despite the patient reporting strict abstinence for the past several months, his symptoms have continued to progress with evidence of worsening structural and conductive heart disease. So this patient's quite young, and he has severe progressive cardiomyopathy with this conduction abnormalities. We wanted to ask ourselves, is there anything we could be missing on our differential? Okay, so unfortunately, our next discussant was going to be Dr. Alex Velasquez, but he got unfortunately stuck in an emergent case at the towers. So he was very sorry that he couldn't be here today, but he did leave us with some slides that we'll go over. Considering this patient's history, we wanted to ask Dr. Velasquez, what should be our approach when evaluating his EKGs and his worsening conduction disease? So he approached this by looking at his EKGs and their changes over time, and noticed that despite diseased fascicles, he also had disease in his AV node, likely caused by fibrosis and sclerosis of the conduction system, which for his age wouldn't be expected from normal aging, although you may expect that in a patient that's much more older than this. He mentioned possible diagnosis, something called Negre disease, that's progressive fibrosis that you see in some young patients. That could explain this level of conduction disease for someone that's so young. And he also mentioned Lev disease. That's a characteristic sclerosis of the left side of the cardiac skeleton, although you would see that in an older patient. So both of these diagnoses, although things to keep on your differential, don't really make sense for this case. He further broadened his possible diagnoses and separated them by possible cardiomyopathies or a different heart disease that could explain these conduction abnormalities. So first, he mentioned infiltrative cardiomyopathy, sarcoidosis, and amyloidosis, which we pretty much ruled out, and the clinical picture may not fit with our cardiac MRI, or acute on chronic myocarditis, possibly of infectious, autoimmune, or from immune checkpoint inhibitors, which is something we're seeing more commonly. Ischemic heart disease and hereditary neuromuscular disorders were also part of the differential, although there's really one of these etiologies that makes more sense to the others, and I'll hand over to Sirisha now.
And I've never been more grateful that Ryan's going into cardiology to step in for that too. So like Ryan said, and like Dr. Weber-Pinzon said, we really want to make sure we're considering these things broadly. It's very easy to box patients into certain categories based on what you hear and what you know and what somebody has labeled in a chart initially and nobody has revisited. So I think one of the things that we want to make sure we talk about here is how do we work through this part of our differential in this category. Things like infiltrative diseases were deemed to be less likely causative for him given his cardiac MRI findings and no other clinical findings on his multiple readmissions consistent with sarcoidosis or amyloidosis. There's no family history and no congenital history that was really concerning for us for hereditary diseases. And then less likely, again, autoimmune findings given his cardiac MRI findings. And then even with this immune checkpoint inhibitor, again, not really applicable for our patient's case. Infectious causes, however, had not been evaluated before, and Chagas serologies were sent at this time. And now, given that you guys are all kind of interested in this direction of our story, that infectious causes of non-ischemic cardiomyopathy are broad, and the diagnosis of Chagas cardiomyopathy is highly specific, we're going to call our final faculty specialist up to assist us with the next step in this case, Dr. Paola Lichtenberger. Dr. Lichtenberger is a professor of clinical medicine at the University of Miami's Miller School of Medicine and chief of ID at the Miami VA healthcare system. Her career is centered on infectious disease education, antimicrobial stewardship, and global health. She's drawn on her extensive clinical leadership and international work to deeply advance educational opportunities in antibiotic stewardship across our campus and across her work in global health. Please welcome Dr. Lichtenberger to the stage. So Dr. Lichtenberger, what would be our best approach for diagnostic and treatment options to something like a Chagas disease in terms of our approach for non-ischemic cardiomyopathy?
Okay, so first of all, thank you for inviting me to this amazing case where I would just jump and say, why you have not checked your Chagas serologies yet? Okay, so there are a couple of things just for all of you. And this is very interesting because remember that we are in Miami. And when I talk about Miami, I talk about Miami, the capital of Latin America. So we have to be very aware about our neighbors. And, 70% of our population is immigrant from Latin America. So take that into account. Always think about. There are a couple of things that right up front, start clicking on my head, not from infectious disease, but as an internist. This guy is very young. How many alcoholics, how many cocaine users we see in our emergency room and they're in their early 40s. So just to begin with, that kind of like a start, my spark of this guy is just not the regular alcoholic drug user. And likely he did not start drinking alcohol 15 years before coming here. It was like probably since he's been here. So it's less than 5 years that he's been drinking alcohol and using drugs. So I'm just leaving you with the question of from day one, you should be very suspicious about that one. When you want to check for serologies, what are the type of things that you want? And I just put it in pictures so everybody feels a little bit more into studying micro with me. First of all, when you want to know about the risk factors, first of all, it's not enough where are you from Latin America that's get Chagas serology. So you have to dip a little bit further into that. Big cities are usually not the hostess for Chagas. There are like, rural areas, can you go to the little house? Where, you know, this type of housing is what you're expecting, okay? Now, we have the modern version of those, and in Texas, we have Chagas, so you have to be aware that it's not that oldie, crappy house. Could be newer house, but as long as there are, like, you know, cracks in the house, that's where the triatom, that is the kissing bug, used to live, and that's the one that carries the Chagas. You have to ask, even people born here, okay? My son, actually, I'm from Chagas endemic area, and my son actually met criteria to be screened for Chagas. If you were born by a mother who lived in endemic areas, should be enough reason to screen for Chagas. If you went to Brazil, if you were and got like this street amazing acai, palm, water fruits, you should be screening. Now, not for the sake of chronic, but in the case of acute events where you have acute cardiomyopathy and you're suspicious that there is acute Chagas, then start thinking about those type of questions. If you are in Texas and you're suspicious about Chagas and you're in close contact with dogs or raccoons, you should be screening for Chagas. And of course, if you have history of blood transfusion or organ donors. Here in the United States since 2007, we do mandatory Chagas screening tests for all the blood, so actually that should not be a concern. More concerning, transplant, because transplant is not as straightforward. So be aware of cardiomyopathies in your transplant. So in these patients, the patient comes from Honduras. So the next question that I ask you guys, do we know where in Honduras he's from? And the other thing is, even if they're from the big cities, one of the questions we forget to ask those deep questions. How did he come from Honduras? Did he walk through the whole thing? He came through an airplane with a passport? Was he in a boat? So those are detailed questions that are telling us a lot about epidemiological risk factors that can give us more into the history. So just having the history of Darius Honduras, do we have any answers in terms of what specifically he was from? Okay, so that's kind of like the same question. And here I have the map a little bit where does, and it is not only to point out Honduras, but it's only to point out Texas and Florida. We have endemic idiopathic cases from Texas. So just for the sake of learning and curiosity about Chagas. Next one. Okay, so how to test the patient. And this is when the complicated thing is that. So we talk about the two type of testing that we have, PCR and serology. PCR is out of the question for chronic infection, okay? So you don't need to use PCR. When you want to use PCR, newborn kids, acute infection, or transplant infection. So those are the three terms when we check for PCR. Sensitivity of PCR in chronic infection is extremely low. So don't get a PCR, don't waste your time. Now, serology. It's not as straightforward because there is no one test that has high enough sensitivity or specificity. Sensitivity and specificity is less than 60% in every single test that we have CLIA approved in the United States. So this is not as easy as go to Quest and get Chagas IgG. And I saw it and I was just like, so if you have questions, I always tell everybody, whenever you have questions about parasitic infections, call me. And if I don't know the answers, we have always Sue Montgomery and CDC to help us to answer the question. The two things is serologists. So you always want to send right up front 2 serologists from different types. So what I recommend is get an ELISA test and an immunofluorescent test. Both of them. One can be positive and the patient may not have Chagas, or may be negative and the patient have Chagas. So at least 2 different types of serology. Now, I am sorry to put commercial names here, but this is in the circumstance where you actually want to know about the commercial names because Quest is not the best, or LabCorp, or those regular tests are not. So you take the phone or go to the lab, talk to Dr. Martinez and tell them which are these we have contact with and try to find out. So Ortho and Wiener are the best because they are CLIA approved and we have very good validation tests for those. So ideally, we should get one of those 2. If we don't have access to any of those, InBios is also good as a screening test, so any of those are very good, but if we don't have, at least make sure that with Quest, you have to talk, and lab has to talk to Quest to make sure that they send ELISA and IFA, because they may do one or the other one and they cancel them. So once you get one, then you get in trouble because you are supposed to get one. So the whole thing is 2 serologic tests based on different antigens. That's the whole idea. Or you go from ELISA and IFA, or whole parasite and recombinant agents. That's the whole idea how you want to do it. You confirm if you have the 2 positives. Now, what if you have 1 positive and 1 negative? Then you're in trouble and you have to go through a 3rd one. And that's when I called Sue Montgomery, because she's the one that can tell me which lab will go and do the third. There are specific lab tests that I will do that one, but it's very difficult to get in touch with them. So it's better to do it through the CDC. That is the radioimmune precipitation test assay. So most of the time when it's available, we do it through the CDC, and they can help us to get it. And as we said before, if you want to make surveillance, then you will order for the PCR and biopsy to save the tissue. Biopsy at this point is not going to be helpful. We are not going to be able to see the pathology. You may have a little bit of the structure of lymphocytic infiltrate in myocardium, but it's not the standard for making a diagnosis. It's only can give you towards that, but it still is not going to take away the fact that you need to do the 2 serology. So the recommendation at this time, it will be to sending right away 2 serologies, different techniques. The most available and rapid fast will be an ELISA and an IFA test, and we'll go from there. Now, even if this patient is not the cardiomyopathy is not related to Chagas, just put it that way, and this comes with a ischemic cardiomyopathy, it's always worth to do the Chagas test. Because if it's positive, even if it's ischemic cardiomyopathy, if this patient ended up going to a heart transplant, you need to make surveillance of the PCR, because the Chagas can recur while they are in with the immunosuppressant. So it's still, even if it's a ischemic cardiomyopathy, it's worth to do it, not for diagnostic, but if you assume that this patient is going to transplant, that's a good idea to have it in right before to make sure. Now, a little bit, they asked me to talk a little bit in terms of treatment or in the guidelines. Do you want me to talk right away, or should we talk later on? Okay, now a little bit about cardiac manifestations. Because we talk Chagas, this is kind of like a book description, and here cardiologists tell me like, yes, that's the disease that I was taking that has this exactly dual presentation. And actually we have data from University of Miami in a retrospective study with all the cardiac patients that we had here with Chagas. And the combination of right bundle branch block and left fascicular is pretty consistent with Chagas infection, dilated cardiomyopathy. And this patient is having, through the whole history of what usually a Chagas patient has, dilated cardiomyopathy, EKG findings, then they get into the stroke, then it gets into the fibrosis and dilated aneurysm, and then they explode the aneurysm, and that's how he used to die in the 50s and then 60s. And the treatment, no, this patient is not a candidate for treatment. So even if we know, unfortunately, the only indication for treatment for this patient will be heart transplant. Actually, these are the patients with the best outcomes from cardiac transplant, because usually they're young and they don't have systemic vascular plaque disease. So actually they do pretty well. And I have a couple of them that I still have, I am in touch with them, and they're doing great. Now, who meets criteria for treatment? The congenital ones, so babies born from mother in age, or people who is positive who does not have any cardiac manifestation yet. Remember, cardiac manifestation is from the immunological response, not directly from the triantamen. So that's not an indication for treatment. Or when they have cardiac transplant, if they have reactivation, like we had a couple of patients here, we had to give the treatment. Treatment, benznidazole, and for the MOX, benznidazole is just FDA approved 5 years ago, so we don't need to go through the CDC. We give it to the patient. Skin rash is probably the only, and we just follow them 3 to 60 days, and they do pretty well with treatment. So,
Perfect. Thank you so much. That was a wonderful overview. And tells us so much what we need to do and what we should be doing better as well. So we did send the immunofixation, the ELISA, the serology returned positive, but like Dr. Lichtenberger said, it was he was deemed ineligible for antiparasitic therapy. His disease was too advanced. It was no longer an acute infection at this time. Once again, we find ourselves undergoing, this time, milrinone-assisted diuresis with appropriate volume optimization. He also, I'm so sorry, this was your slide.
No, it's okay. Yeah. No, and essentially, yes, we before he was discharged, there was a rhythm control strategy, and he underwent TE with direct current cardioversion and was successfully converted to normal sinus rhythm.
To this day, he does still have recurrent episodes of acute decompensated heart failure. He has been recently readmitted several times after that most recent episode. He continues to be evaluated by cardiology. However, again, not a candidate for advanced therapies like transplant, like mechanical therapy, because of ongoing psychosocial barriers and ongoing lack of insurance. He is under close cardiology follow-up, and he is medication compliant. So we want to go over some 3 key takeaways for you guys here with regards to this case. And I think both Dr. Weber-Pinzon and Dr. Lichtenberger really hit on what we, working in Jackson inpatient and at University of Miami, see day in and day out, but really keeping that broad differential for etiologies of non-ischemic cardiomyopathies. But as they both mentioned too, focusing on your patient's risk factors and taking their clinical history into consideration when making your differentials and diagnostic choices. Remembering these characteristic findings next time you come across an ECG for a patient in dilated non-ischemic cardiomyopathy, for considering Chagas cardiomyopathy on your differential. And if they have acute infections, your patients can be treated and can have meaningful changes in their outcome. And even from the post-transplant perspective, had this patient been a candidate for transplant, had his insurance worked out, had he had better psychosocial circumstances, would have been a better outcome for him too. We did just want to give a quick, oh no, it got cut off, plug for a recent article in JAMA that I know the cardiology.
Yeah, so funny enough, this was presented in Journal Club this morning by one of our excellent residents, Christian Guillot, and then also moderated by Dr. Weber-Pinzon. So this was already on everybody's mind this morning, but this is the first large multi-center randomized clinical trial that has anything to do with Chagas, really. And interestingly enough, it just evaluated Entresto versus enalapril. It's worth a read, worth consideration. It's good to know that at least there's data coming out for Chagas and for this population that previously has been extremely underserved and underrepresented in the literature.
Thank you, both of you, and for both our speakers. Thank you very much. That was excellent. Let me ask a couple, at least start off with a question. So the tricuspid regurg seemed to have been a very important component of this, and whereas the mitral valve you were able to clip and maybe provided some symptomatic relief from that, why was a tricuspid clipping not considered?
Yeah, and I think with that second echo, that repeat, we just wanted to show that there was worsening structural heart disease that was now affecting the right side and therefore affecting in like a secondary fashion the tricuspid valve. There are interventions, transcatheter edge-to-edge repair for tricuspid valves, although those are just recently coming out and are not broadly performed in many institutions just yet.
But I think we performed them here.
Yeah, for sure. Yeah.
So are we
could
going to
be
give him that option?
I think in the future, sure. Yeah. If it may relieve some symptoms, potentially.
Again, knowing him and his clinical history and his barriers to care, it's also something that.
So let's talk a little bit about his barriers to care, because sometimes just as we can assume that the diagnosis was alcoholic cardiomyopathy, we assume that social conditions can't be changed. But in fact, although difficult to do so, what attempts have been made to affect changes in his social conditions that could likely prolong his life and allow him to get some life-changing disease therapy?
Yeah, I think, it's such a difficult process, something we struggle with many of our patients in, a multitude of different types of scenarios. And I think we do our best to connect them with the social services we have available, which are already at baseline severely stressed. A patient like this potentially could qualify maybe for Medicare, and it could eventually become an option, although that process can be quite difficult, especially if they're not as well versed in the process and accomplishing things like that. Anytime this patient's here, we do our best to connect them with the right services, but it's not always easy and extremely feasible, unfortunately.
Yeah, that's not an excuse, unfortunately. So did he speak English?
No, this patient was primarily Spanish speaking.
So how did you assess, are you native Spanish speakers? So you were able to, and you took care of him?
Yes, I did take care of him for a point in time, yeah.
And so in your long discussions with him, which I'm sure you had, what was your assessment of his barriers for being able to overcome?
Yeah, I think, a big portion unfortunately, financial. Um,
Things like advanced therapies, there's a component of psychosocial support, which I know we've referenced a couple times. Social support being if you do not have familial support, if you do not have somebody to care for you in the long-term recovery process for things, it's like a non-starter. I do not pass go in terms of therapies. Things like transplant, you cannot be listed for certain evaluations like transplant without connections to insurance, without having that strong psychosocial support, without documented abstinence for certain periods of time. So there are, which he did have, but the other things that are outside of his control, the access to insurance, the access to the social support, are things that as an institution we can help with so many things. And I think we were able to help with the abstinence portion, but beyond that.
Okay. In terms of end organ effects of Chagas disease, we talked about the heart. Was there any other organ system like the esophagus or any other evaluations that one might want to do to look at other organ system involvement?
Yeah, so usually, as we all know, Chagas can mainly affect or your coronary, your cardiovascular system or your GI tract. So the patient will benefit from a barium swallow and colostomy. Although we know that depending on the region that we are, as Honduras, is mainly cardiac infection. And we know nowadays that depending on the strain of the Chagas parasite, it may be one presentation or the other. But as per guidelines, the patient should have a complete workup, having the GI workup. That should be done. Although at this point, we know that no matter what, the only treatment and the only hope that this patient have is a cardiac transplant.
Is there any value, given that he has other family members that he lives with that might have also been exposed but are still in a preclinical stage who might benefit from some early treatment? What is the recommendations regarding that?
Every single family member born in the same or sharing the same situation should all get the screen. Actually, we do with all the family members, with the patients, not only to ask them to screen for those who live here, but also those who live in Honduras. Like most of the people that we have here is from Honduras, so we ask them to ask their family members back in town to get the test done. And just a little message for all of you that do primary care, ask where they are from and do the screening test. Don't wait that late. Especially women on reproductive age, is always better to have a negative test and to avoid or a vertical transmission or a problem like this than where it's actually too late.
Any second to last comments, Dr. Pinzon?
No, I think I already said it. I think always keep your differential broad. There again, typical EKG changes, echocardiographic changes with segmental wall motion abnormalities that are not explained by coronary artery disease, big aneurysms of the left ventricle more commonly, but the right ventricle can also get involved. You see big LV thrombus, strokes. Those are big buzzwords for Chagas.
Wait, so they can hear you.
Me and my last little tips and messages for Chagas is, please keep that with you. There's no idiopathic cardiomyopathy on an American patient without a negative Chagas test.
Okay, well, that's a very good note to end on. I want to thank our expert presenters. I want to thank our chief residents for doing a wonderful job, and I don't want to neglect thanks to Dr. Deshpande, who tutored our chief residents and got them to this marvelous presentation. I want to remind everybody to check the QR code on your out as you exit for your MOC and CME credits. And I wish everybody a great day, and I look forward to seeing you next week. So take good care of yourselves.